Okay, I guess we're getting started. Welcome to our webinar on the drug overdose crisis and policy responses. My name is Sandra Bucerius, and I will be moderating today's conversations, which will cover the impact of prison dynamics on the opioid epidemic, NGOs' work on education, collaboration, and prevention to reduce DODs, and policy responses to the overdose crisis. On behalf of all of the panelists, I want to thank the Orion Policy Institute for inviting us. We will each speak for about 10 to 12 minutes and have some time for the Q&A at the end. So I would ask everyone to hold their questions for the end of the session. I will begin today and I will be sharing my screen. I hope this will work. Can you see that? Yes, okay. So because I'm moderating, I will actually be introducing myself. I'm a professor for sociology and criminology at the University of Alberta, and I'm also the director of its Center for Criminological Research, and I'm also the director of the University of Alberta Prison Project. I want to acknowledge that I'm speaking to you from Treaty 6 territory in Edmonton, which is the traditional lands of First Nations and Métis people. So I will be presenting on behalf of our larger team of the University of Alberta Prison Project, which is a multi-year, multi-method examination of prison life in Western Canada. And I will be talking specifically about our research on the dynamics of the overdose crisis in Western Canada. My talk will have less of a policy focus, but I will shed light on how the overdose crisis is playing out behind prison bars. And I will be leaning on an article that I published with Dr. Haggerty in the International Journal of Drug Policy. And this paper actually touches on prison dynamics and how they've changed for incarcerated people and for correctional staff during the overdose crisis. But today I will only have time to discuss the impact on the incarcerated population. Before I start, just some quick background factors on Canada. So a 2015 United Nations report found Canadians to be the world's second largest per capita consumers for opioids. In 2015, Canadian doctors actually wrote enough opioid prescriptions to provide 1 in every 2 of Canada's 36 million citizens with a prescription. And as in other places, fentanyl and its analogs have flooded the Canadian market in recent years. Fatal overdoses resulting from the use of these opioids have been increasing at an alarming rate in Canada, with about 8 people dying per day in 2016. 12 in 2018 and 20 in 2022. And since 2015, the 2 Western Canadian provinces, Alberta, where we conduct our research, and British Columbia, lead the country's opioid-related mortality rates. Now, as is common with many other public health emergencies, the risks associated with opioid use are most pronounced for marginalized people and members of society. And prisons figure prominently into this equation, as they tend to house a disproportionate number of individuals with history of substance use, street involvement, and mental illness. Incarcerated individuals also suffer disproportionately from other health-related concerns, including HIV, hepatitis C, tuberculosis, and so on. And so consequently, prisons house a disproportionate number of opioid users and appear to be acute concentration points for the use and the attendant risks of powerful new synthetic opioids. I will now spend some time talking about the presence of opioids in prisons, particularly fentanyl, and how that has changed the prison dynamics in Western Canada. So to date, and as part of the University of Alberta Prison Project, we have conducted research in 6 prisons and jails in Western Canada, where we've conducted semi-structured interviews and surveys with close to 750 incarcerated individuals and 190 staff. Now, there's a huge caveat that I need to mention, in that these interviews and surveys were conducted between 2016 and 2020, so before the onset of the pandemic. And I cannot speak to how dynamics have changed since. Now, related to the overdose crisis, we asked several questions that you can see on the slide here, though I will only be talking about the first point today. Now, in terms of our participants' drug-related experiences, this is an incarcerated population with considerable histories of drug use and drug involvement. For example, for the federally incarcerated women in our sample, 85.2% reported a regular pattern of personal drug use outside of prison, and 55% reported using illicit drugs while incarcerated. To that point, our findings suggest that despite efforts by correctional officers to control the drug trade, opioids and other drugs are often widely available in Canadian prisons, especially in remand facilities where people await trial. The turnover rate in remand is very high. People get constantly admitted. The average length of stay is just a bit more than 2 weeks. So remanded incarcerated individuals are regularly moved into the prison and regularly moved within the prison to attend court hearings, for example, or to meet their lawyers. And such constant movement makes it relatively easy for incarcerated individuals to smuggle drugs into the prison and to move it around between different units. So here, as one person told us, some of the gangs, it's their business to run the drug trade in here. They look around for little kids who have cash bail. They get the money together, bail the kid out, tell them to pack up outside, and then come back in, like get yourself picked up by the cops, go back to remand. So incarcerated individuals actually identified 4 areas where the presence of fentanyl and the overdose crisis has had a profound impact on the dynamics of prison units. The first point is that it has increased the number of overdoses in comparison to before the onset of the overdose crisis. And so to this point, nearly every incarcerated individual we spoke with told a story about how someone they knew overdosed in prison. And this was alarming, but also increasingly normalized among the population. Correctional ministries do not release statistics on overdoses in our jurisdictions, but our conversations with correctional managers and officers and nurses suggest that the number of overdoses in a given month on a particular unit at the time when we did the data collection ranged between 0 and 9, depending on the facility. And I've certainly done interviews on units where 9 people had overdosed in the previous month. So seeing people overdose on a regular basis in this prison space obviously has huge implications on the emotional well-being of both incarcerated people and the staff. Now, while our participants talked about the stark increase in overdoses in prisons since the onset of the overdose crisis. The second point that they mentioned is that, nevertheless, they also perceived prisons to be a comparatively safe place to use drugs, which was interesting. And that is, I believe, because naloxone is available. Staff do have access to naloxone in Canada, and they monitor incarcerated individuals for overdose symptoms, and incarcerated individuals typically use in the presence of another incarcerated individual who could potentially inform nearby staff in the event of an overdose. So as you see on the slide here, one participant says, you take turns, kind of like spotting at the gym. Now, the third point that our participants mentioned is that there was a very common presence of fentanyl starting in around 2015-16, but that fentanyl was also used and mixed with many other drugs. So, for example, this individual here says it's everywhere, it's in your cocaine, it's everywhere. So because fentanyl was perceived to be mixed with everything in the perception of our participants, and because incarcerated people have a little idea of what substances arrived in prison and how they've been mixed on the outside, a considerable portion of fentanyl use consequently appears to be unintentional or inadvertent, so consumed by users who thought that they were maybe ingesting a different drug. And that is obviously a situation that significantly increases the chances of accidental overdoses or also fatalities. And now I'm coming to point 4, which is, I think, unique about prison and maybe the most interesting. Many of our participants focused their comments on how the overdose crisis and fentanyl has changed the relationships between incarcerated individuals. So, for example, sharing food in prison is one of the ways in which incarcerated individuals can enjoy socially reciprocal interactions that are commonplace outside of prison, that are commonplace for us. So, for example, sharing birthday cakes made from snacks purchased through the canteen is a well-established ritual in prison that helps maintain some semblance of normalcy while incarcerated. But our data show that some incarcerated individuals are increasingly now nervous about such practices, and some individuals refuse to consume anything that isn't pre-packaged. So, for example, a participant here explained, you don't know what's in that bag of chips, you can't trust no one anymore, anything can be laced, the chips can be laced. Now, that fear was most common among incarcerated individuals involved in organized crime, who likely had more reasons to be fearing for their lives. From the same individuals, we heard rumors that some deaths are in prison staged as overdoses. So, for example, comments like, not every overdose you see is actually an overdose. It's called Mr. Murder for a reason. Or, excuse the language, they put a fucking straw in your nose, blow fentanyl up your brain, perfect overdose, no one can prove anything. Now, whether this is happening, actually happening for us is impossible to determine given the lack of official release of data. And we, of course, do believe that the prospect of actually blowing fentanyl into someone's nose is extremely unlikely, but nonetheless, we regularly heard about such fears relating to the prospect that fentanyl could be used as a weapon, both by incarcerated individuals and by staff. Okay, so this is a super quick summary of how fentanyl and the overdose crisis is playing out behind bars for incarcerated individuals. Now, what does this mean for policy? Well, while certain responses are already in place, such as the availability of naloxone, others might be obvious harm reduction responses, but they may actually not work in prison given these unique fears of the population in that particular place. So when thinking about any policy response in prison, its unique context and dynamics need to be considered. Prisons are very complicated and unique places, meaning that to be successful, harm reduction initiatives must be cognizant of the institutional and logistical and cultural aspects of prison life. Prison dynamics, this is important to remember, differ from country to country, from jurisdiction to jurisdiction, and from prison to prison. I always say, if you know one prison, you know exactly one prison. The next one might work differently. And what might work in prisons in Switzerland may not work in Western Canada because of the unique subcultural dynamics, the gang activities, relationship between staff and incarcerated population, and so on and so forth. So harm reduction measures, that's also important for activists to remember, that may work in the community, may not be welcome in prison, not just because they may not be accepted by the staff who essentially need to implement them, but because they may also not be supported by the incarcerated population either because of their unique fears. Our piece, Sticking Points, that was on the slide earlier that we just published in the journal Incarceration, shows just that incarcerated women in our sample had a very strong resistance to a needle exchange program that was implemented in prison. And similarly, a safe consumption site that has been implemented in 2 of the federal prisons in our province had next to no uptake. So my main message when thinking about policy responses to the overdose crisis in prison is that it would be detrimental to introduce any harm reduction measures in prison without carefully consulting with the incarcerated population while they are incarcerated, while they're in that space, and the staff in that particular prison to understand their concerns and their fears and their perhaps deeply held misconceptions about topics. And without an appreciation for the dynamics in that place and the subcultural dynamics, well-intended and evidence-based programs probably fail. And that's it for me. And I will now give over to the next speaker, Larissa Mayo. I'm just going to stop sharing. So Larissa is an international drug policy expert from Switzerland, and is a member of the core research team at the Global Drug Survey. And she's currently traveling in South America to learn more about indigenous culture, plant medicine, and community healing. So over to you, Larissa. Thank you.
Thank you so much, Sandra. And this description is almost a little bit outdated because I did travel in South America all of last year. And just yesterday, I got back to Zurich. So I'll spend 1 month here and then be on the road again, but it's going to be more around Europe and the US for other conference trips and travels related to community projects. So everything related to overdose prevention is really close to my heart because I know that every overdose death from the start in Switzerland, we had overdose crisis in the 90s as well. We were dealing with this, and there were up to 350 people per year who were dying. So that is, of course, not comparable at scale to what is happening in the United States right now. But it's still to give you a little background to where I'm from. I started studying psychology because I was interested in people and how they differ from the norm, or what was considered the norm. And obviously, we learned early on that drugs are bad and that they're destroying communities. But growing up in Switzerland near Zurich, which is kind of a big city considered at least here, showed us early that a lot of young people were using drugs, not necessarily opioids, and there were no reported overdose deaths at the time among young people. But at the same time, we learned that drug use doesn't necessarily have to be harmful. So harm reduction could also take place in settings where recreational drug use was common. And from that perspective, I was really interested in the drug checking projects. So in Switzerland, people who use drugs, no matter whether it's recreational or in an addictive behavior, they have the chance to actually analyze their drugs, not just for the content, but also for the purity of the substances, so that they know what they're using and they can make a more informed decision whether to use the substance at all or what proportion of the substance you used based on the result. And right now, a new paper was just published where they analyzed the drug checking results from about 16,000 samples from 2011 to 2021. And they were showing that about 57% of the drugs tested had different results than expected. So then again, it's left to the person who wants to use the drug, whether they want to continue with the use or continue with the use in the planned form. But basically, that is the result from a Swiss drug checking service that has been running and operating for years, that has also contributed to kind of ensure quality to a certain point with the unregulated market. We have to be clear that the risks of overdose are highly increased in markets where prohibition is in place, because the access to black markets in general is not providing the possibility to actually know what people are using. But then on the other hand, most of the overdose deaths we see in the United States, we also have to see that the people who use drugs are experts in the use. So they are basically knowing what they're using. And a lot of people, like in San Francisco, where I was doing my postdoc from 2018 to 21, they knew exactly when they were using fentanyl, and they were using it intentionally, and they were also more or less knowing about the dose based on the information provided by the dealer. So the only cases where someone is using a higher dose than expected or than usual is when they're having exceptional emotional or physical pain, or when they're in a community where different substances are handed around, where it's not entirely clear what the substance is. And then, of course, another problem is mixed substance use, and not just with other drugs that are illegal, but also with benzodiazepines, prescription drugs, and alcohol. So these are extremely stressful situations for people's bodies. And during my time in San Francisco, I was volunteering with the syringe access program. And a lot of times we hear that the people on the street are super psychotic and so on. But my experience was really different. Like, I learned a lot about the people, and I learned about their lives and their stories. And many of them, again, those who were using the services, had really good ways to reduce harm, and they were also cognizant of strategies to help their peers. So that's another statistic that is important. Most of the overdose deaths that are reversed by peers. It's reversed by other people who use drugs. While it's nice that we want police and every school and everyone to carry naloxone, we have to be clear that the people who are closest to the people and responding to an overdose are, for the most part, other people who use drugs or social workers who are related to these people. And again, the risk of overdose is highest when people are using alone. That has also been seen during the pandemic. In San Francisco, for example, many people who were unhoused were put into hotel rooms and isolated. Even like cigarettes, alcohol, or cannabis was delivered to them, because obviously California is a state where the use of cannabis for recreational or any purpose is legalized for adults. So by having people in the hotels isolated without going home, without being part of the, without going out, and I said home because the streets are oftentimes their home, they didn't have access to community and many important support resources, because what might look as chaos for some of us on the streets is sometimes very organized, because they know exactly who is there to help them if in need. So from that standpoint of view, of course, what we want to do is like look at the early prevention. Like, how can we look closer to people who use drugs and their patterns as they change, and maybe not just at the stage of a severe addiction, but maybe earlier on. That would also mean that the employers would be to be informed, like if people are losing their housing or if they're showing patterns of substance use that are more difficult. It's of course important to actually learn more about the circumstances and potentially provide options. Now, what can we do from a policy standpoint? In Switzerland in 2008, we had a model that was introduced with the 4 pillars, where harm reduction became one of the 4 pillars, in addition to prevention, treatment, and harm reduction that was already in addition to prevention, treatment, and supply measures to repress substance use. And what we've seen over and over again since the war on drugs was basically introduced by Nixon in 1971, followed by the UN conventions that also scheduled the drugs, is that in places where prohibition is enforced, we see greater harms of people who use drugs and obviously greater overdose risks. So while not everyone wants to go to treatment, what can we do? We can provide safe spaces for people who use drugs. You all in the audience, and it's very nice to see some familiar names there, know how you kind of have a drink at a bar, or how people are using drugs in parties or in private spaces. So any of these spaces really is a supervised consumption space, whereas a lot of people who are showing more stigmatized drug use behaviors do not have access to such spaces. In San Francisco, we had a model site that was shown to the public in 2018, and the public showed like kind of consent and was ready to move on with such a site. There is, of course, spaces that are working more underground, but then a legal space would really be helpful, so people have a place to go and also get organized and learn about other projects. So this was passed by the government and the California Senate and the House for twice, but 2 times the governor vetoed it. So despite the population and also the state legislators saying that this would be a good move, the governors didn't move forward with it because they were afraid to lose kind of support from their stakeholders. We have to be clear that the syringe access programs are great. They're not implemented everywhere in the US too, but they're only helping to reduce like the HIV risk or the risk of transmission of HIV and AIDS. And a study that evaluated the whole package in Switzerland showed that if we had implemented the whole harm reduction package 2 years earlier, we could have prevented more than 3,500 or more than 3,000 HIV new infections and more than 1,500 AIDS-related deaths. So now we're talking of a drug epidemic still, and the measures that are put out are just put out way too slow. Still, we have a lot of neighbors and people who do not want to see the sites opening in front of their houses, because obviously they work hard and they pay for living in a good zone. From that perspective, it's important to acknowledge that the way forward is really building community spaces for people who use drugs. If we cannot provide housing and places where they can use drugs as long as they are addicted and as long as they do not wish to change their behavior, we have to move forward with open sites. And in San Francisco, a drug dealing task force was also looking at the street level drug dealing. And one of the things discussed there was also an open safe dealing zone to take away the crime and the violence related to drug use or to the drug trafficking specifically, because it would, in the next few years, it will not change that a lot of people sit there who are addicted to drugs and will use these drugs. So with the rising numbers of overdose deaths in general, and it's for California, for example, more than 6,000 deaths related to opioids, and out of them, more than 5,000 related to fentanyl, which has been introduced in the drug markets and is a direct consequence of strong supply reduction measures related to heroin. It is really time to become more progressive and find ways to work with the people who use drugs to find solutions that work for them as of today, based on the needs of today. And all the options should really link up and see what is the desire of these people, and that's what harm reduction is about. We want to meet people where they're at to prevent overdoses and to ensure that they have support projects that help them out to stabilization and to a more dignity and respectful way of life, because we are all people, and people who use drugs obviously deserve to be part of our society. They have a lot of talents that we can use, but first we need to provide spaces for them to kind of provide answers and information about what they want to do. So I do hope that policy in the United States and worldwide is moving forward with more acceptance, tolerance, and respect towards people who use drugs, that we can implement more harm reduction early on that will also save us costs of long-term medical problems, and that we can move towards a public health-oriented human rights approach where we really have the person who uses drugs at the center and not the profits of the addiction treatment center as it is as of today. I want to close with saying that there are options to help people quit drug use or also quit opioid use that haven't been fully researched. For example, ibogaine is a psychedelic drug that is very potent, and of course not everyone can use it. In San Francisco, for example, a lot of people use both opioids and also methamphetamine. In that part, it's very important because ibogaine is strong on the heart. If you're using stimulants, you cannot really, if you have a co-use of stimulants, this may not be the medicine that is indicated, but there are several alternatives in the plant medicines that can be explored in the future, and that's definitely a path that we also want to look at.
Thank you, Larissa. Super interesting. And we are moving to Karina Havenstreit, who is the program manager at the County District Attorney's Office, and she worked in the Overdose Fatality Review Team. Welcome, Karina.
Thank you. So yes, I am Karina Havenstreit, and I'm with the Lackawanna County District Attorney's Office. And today I'm going to be talking to you briefly about the development, the achievements, and some of the hurdles surrounding our Overdose Fatality Review Team. So I'm just going to start by briefly, talking about what is Overdose Fatality Review, or OFR, as I will refer to it moving forward. So essentially, OFR is really an in-depth examination or a deep dive into the lives of people who have unfortunately died of an overdose death. So it's really, an interdisciplinary team of key community stakeholders all getting together and working collaboratively to really look at these overdose deaths and try to understand what led to them. So we try to look at what factors led to the death, identify gaps in treatment and missed opportunities for intervention, and develop and implement recommendations to hopefully prevent overdose deaths in the future. So OFR helps to increase collaboration among agencies, increase understanding of the true cause of overdose death, decrease stigma, and develop and implement data-driven responses for change. So just a little background on our team. our overdose fatality review team. So in 2019, the district attorney's office was awarded a grant by the Department of Justice to develop an overdose fatality review team. I was brought on to develop this team in February, and then of course the COVID-19 pandemic hit. So there is already so many confidentiality concerns that surround overdose fatality review that having to move, what was meant to be an in-person initiative into a digital space really complicated things and did cause some delays, but we did get there in the end. We had our first informational buy-in meeting in August of 2020. We held our first identified case reviews in October of 2020. So we have held a monthly meeting every single month since then. We typically review 2 cases per month. So we've reviewed over 45 cases of overdose deaths within Lackawanna County. And we actually were also awarded an additional grant in October of 2022 to expand the efforts of our team and continue to, support some of the great work that we're doing. So a lot of times once I talk to people about OFR and they kind of agree with, hey, it sounds like a good idea, but like, what does it actually look like? So I work with teams all over the country, and I will say that every team functions differently. A lot of times that has a lot to do with what the policies and procedures and laws are in the states and jurisdictions that the OFR teams function in, and also, who is leading the team. It's pretty unusual to see a district attorney's office like ours leading an overdose fatality review team. A lot of times they're led by the Department of Health, and there's, benefits to both. But for us, the way that it works is that I essentially provide the name, date of birth, and date of death of the cases that we're going to be reviewing to all of the members of our team at least 2 to 3 weeks prior to the meeting. And then everyone gathers any information or touch points that they had with that particular individual. On the day of the meeting, I start by reporting out basic demographics, as well as any information we got from the obituary or social media. I also include pictures of the decedent for every review we do, because I really think it helps to, get people to see these as, human beings instead of as just case reviews. So, bringing that human factor and understanding that these cases that we are reviewing are real people. So after I report out basic information, we go around and every member of the team reports out any touch points and any information that they had with that individual. So then through discussion, we would then identify any risk factors that could have led to the overdose death, gaps in care, any issues or topics that arose for discussion. And then we develop recommendations based on that information. So we develop recommendations on how this particular death could have been prevented, how we could have done better, where we could have possibly intervened, and how we could have prevented possible overdose deaths in the future. We also include next of kin interviews with every single case we reviewed. So we do also present to the team, information from the family members about, their childhood and their path to addiction, which can also provide a lot of really, strong information. We also generate semi-annual data and recommendation meetings and reports that are shared with our team. So now that you understand a little bit about what our OFR teams look like, people also commonly ask, okay, so everybody is sitting down and talking about, these deaths and really trying to understand them, but what is coming out of the team? What are the actual things that are happening? So I'm just going to take a couple of minutes to talk about some of the recommendations that we've generated and some of the change that we've seen. So one thing which we've talked about is the expansion of naloxone or Narcan access. So we did develop a naloxone by mail initiative that we distributed over 750 recovery kits, which include naloxone and all kinds of community harm reduction resources by mail throughout our community. Unfortunately, you know, rural Pennsylvania is much, much different than California in pretty much every aspect of everything. So it's so interesting to be listening to Larissa present, you know, about what's going on in California compared to kind of what we have going on, you know, in Pennsylvania. So another thing that we had was just really looking deeply into our fentanyl statistics. So when we started looking at our overdose deaths, we started seeing some trends and really digging deep into what our fentanyl data looked like. So we did find that in 2021, fentanyl was in 82% of opioid-related overdoses nationally in the United States. And for us, it was in 97% of our opioid-related overdoses. So we are very much like, we have a drug supply that is completely saturated with fentanyl. And we also saw a 168% increase in fentanyl-only deaths from 2020 to 2021. And another thing we found is that there was less than 40% of the opioid-related overdoses we had heroin in their system. So when we were, you know, talking to people, a lot of people, you know, were equating overdose death with heroin use, but that is not at all what we were seeing. So once we dove deep into that data, we decided that we obviously needed to educate the public, you know, on those things. So our district attorney, our chief of police, and our mayor got together and we held a press conference and really talked about our local data and how the risk of overdose death was in everything. And, you know, that our drug detectives were seeing, you know, fentanyl disguised as brown powder heroin, and that we were seeing fentanyl pressed into pill form. And, you know, we had kids who were thinking they were taking a Xanax or a Percocet and were taking fentanyl and dying of overdoses. So we really tried to raise some awareness. We also created a fentanyl education document that was distributed in our community. And that press conference led to a lot of discussion surrounding the decriminalization of fentanyl testing strips, which is crazy, but was still illegal in Pennsylvania up until October. So actually, that press conference led to a lot of discussion about fentanyl testing strips. We were unfortunately unable to pass it on a local level, but we got a lot of support and were able to really push and support some legislation on the state level. And we are very proud to say that in October of 2020, Pennsylvania did pass decriminalization of fentanyl testing strips, as well as legislation to support overdose fatality review, which are both huge steps in the right direction for us for a harm reduction standpoint. Another thing we see a lot in our overdose fatality review is a lot of discussion around childhood trauma and ACE scores and really doing early intervention to try to prevent drug use to begin with. So we recently, after 2 years of pursuing funding, we just got a grant in October to implement a program that will provide targeted services and linkage to care for children impacted by parental and caregiver drug and alcohol use. So that is another initiative that is coming directly out of the recommendations and data supplied by our OFR team. We also developed a grief resource pamphlet, which we use for all of our next of kin interviews, as well as we are working to develop a non-substance related addiction policy and procedure for the county, because we've had multiple cases where gambling was a very large contributing factor in addiction, which is another thing that we never really, I don't think, would have ever thought of without really looking into these cases and these people's lives and, you know, what their path of addiction looked like. We've also had some unbelievable opportunities to, you know, share our overdose fatality review journey and our achievements. So in 2021, I was able to digitally present at the OFR National Forum, as well as the National COSAP Conference, which is a conference through the Department of Justice. And actually in January, I was able to act as a plenary speaker at the National OFR Forum in Washington, DC, in front of almost 1,000 people, which was terrifying, but amazing to share, you know, what we're doing in our, you know, small, pretty rural area, you know, to really work to make some real change. And, you know, how overdose fatality review has worked for us. We were also featured in Keeping Up with COSAP, which is a joint publication of the Bureau of Justice Assistance and the Institute of Intergovernmental Research. And we are excited this year to be one of only 11 mentor sites in the country who is going to be providing mentorship throughout the United States for overdose fatality review teams developing in the country. So we've had, a really interesting journey over the last 3 years. And for us, overdose fatality review has really helped to shed a lot of light and understanding on what is happening in our local community and what we really might be able to do to make some real change to prevent overdose deaths in the future.
Thank you, Karina. Also very interesting talk. We will go to our last speaker. So I'm welcoming Susan Bissett, who is the president of the West Virginia Drug Intervention Institute, and she is committed to reducing overdose deaths in West Virginia. She has over 25 years of administrative experience with nonprofits and higher education. Welcome, Susan.
Thank you, Sandra, and thank you, Karina and Larissa, because everything you said is really going to help me to kind of springboard. I want to talk about 3 things in particular today, and so my focus is going to be more on putting policy into action. And so we are in a unique situation in West Virginia, and the Institute is now referring to ourselves as the Drug Intervention Institute because we are expanding our focus beyond the state into Appalachia in particular, but also the nation. And so there are 3 aspects that I think are really important to talk about today. One is education. One is the fentanyl test strip concern, West Virginia. Interestingly enough, I made note that Pennsylvania just decriminalized them in October. West Virginia did that in June. And so it's been interesting to see, and I have some comments about how that's worked on our end in terms of distribution. And then I want to kind of unpack the whole issue of naloxone, especially in the recent announcement from the FDA last week that the brand Narcan, I know sometimes we like to say Narcan in place of naloxone, but Narcan is the brand name for the naloxone formulation that went over the counter. There are certainly lots of other formulations, and I'll talk a little bit about that as well. I'll also just share with you that I'm fascinated when I hear people talk about how other countries are responding to the opioid crisis, because I think the United States is a little bit behind. We profess that we advocate for harm reduction, but in my state, we have seen syringe service programs cut in large part because of legislation that put some pretty prohibitive regulations in front of any site that wants to, in particular, do syringe exchange. So I was very much a part of watching that happen, and it was very sad. And I know some folks and some patients that went through the harm reduction program here in Kanawha County where I volunteered who have since passed. And I often wonder if they would still be with us had that harm reduction and syringe service program not shut down. So unfortunately, we have a nasty little bill that was passed a couple of years ago, Senate Bill 334, that put significant restrictions on syringe service programs here in the state. And so we've had kind of an uphill battle. We are seeing our overdoses trend a little bit down. I think everyone is to some degree, but I also like to remind people that trending down from pandemic numbers is not trending down. I will not be satisfied until I start seeing numbers trend down significantly from pre-pandemic numbers. The comments that have been made on fentanyl are spot on. When I started this work, I was an assistant dean at a pharmacy school. Most of the overdoses that we were seeing happen were prescription pills and then moved on to heroin. And now fentanyl has just proliferated the drug supply. And so it is a different ball game when we're talking about preventing overdose. We're not just talking about preventing overdose for persons in active use or in active addiction. We're talking about preventing overdose for the group of young people that might be trying cocaine for the first time and experimenting with it in an apartment in Seattle. We're talking about college students who are taking counterfeit Adderall pills at the Ohio State University who passed away. We're talking about children who are getting a hold of fentanyl as well as prescription drugs in the home. And in West Virginia in particular, in direct result of the opioid epidemic, we have a very large number of children being raised, not just by foster care, the foster care system, but by grandparents. And unfortunately, what has happened with those children is they're in the kinship care situation because their parents had issues with the misuse of prescription or illicit drugs. We're taking those children, we're putting into them a seemingly safer environment, but those particular individuals that they're placed with tend to not store their medications properly. We know older persons tend to not do that. Mama and Papa have them on their end table on the kitchen counter where kids can easily reach them. They're more likely to have an opioid prescription, and they're more likely to have multiple prescriptions. And so we've got to be able to reach that population. So I say all of that with the context of three things that the Institute has been doing. One is education, and we're starting with very, very young children. So we have a program called Don't Keep Rex Around, which is a medication safety program that started out by talking to pre-K, if you can imagine, pre-K and kindergarten students about medication safety. And we created that program in large part because an assistant superintendent of a county here in West Virginia called us and said, we have had 2, 4, and 5-year-olds overdose by taking their grandparents' opioid medication, and we need to get to kids early and often. And so as the parent of young adults, that was a very challenging opportunity that presented itself to us, and we were able to develop an interactive cartoon avatar that talks to young kids about the importance of medication safety and works with the protective factors of talking to your trusted adult. Okay, obviously we're not teaching 4 and 5-year-olds how to take medication. We want them to know that medication is sometimes a necessary thing, but it's not something you share, touch, etc., without the help of a trusted adult. We've expanded that messaging to include PSAs for grandparents and parents and foster families, because part of how the opioid epidemic started was very well-intended people saying, oh, you hurt your back? I had this medication when I broke my leg, let me share it with you. And so we need to continue having those conversations around medication safety, even though we're still looking at a very different opioid epidemic. The second piece is the fentanyl test strip piece. And I had mentioned that in West Virginia, those just became decriminalized in June. And since that time, we've had 2 or 3 organizations that have been very, very proactive about distributing fentanyl test strips throughout the state. And so we started a very robust fentanyl test strip distribution program and have distributed since September over 55,000 fentanyl test strips to 50 counties in West Virginia. And while that might not seem significant, when you think about a state the size of West Virginia, that is very, very significant. And so I think it's important that, unfortunately, what has happened is that's not funded well. And so we have made an intention after we ran out of funding to continue to fund that project. We're currently looking at ways that we can fund it better and better coordinate those efforts throughout the state, because West Virginia is a very odd shaped state. It is a very rural state. And so what we're working on now is to identify folks through behavioral health and DHHR here in West Virginia to identify 5 or 6 organizations regionally, us being one, that can distribute those out into the community, to harm reduction organizations, to health departments. We even have parents call and request them. I did just want to share that I think a word of caution about fentanyl test strips. They're not a magic bullet. I'm hearing from pharmacists that sometimes they're not picking up some of the strains of fentanyl, and so that's a concern. I think the other concern from my perspective has always been when you look at other what they're called point of care testing. So when you take a rapid strep test or a rapid HIV or a rapid hep C or even a pregnancy test, 2 lines on that test mean positive. On some of these fentanyl test strips, 1 line is positive. And so I think along with distributing the fentanyl test strips, we need to be really cognizant that there needs to be some education around not only how to use them, but that one line is positive, right? Because the average person is used to 2 lines being positive. Think about COVID. 2 lines were positive. So just a word of caution about those as we're distributing them and it becomes more available in more states are following Pennsylvania and West Virginia, thank God. We need to make sure that not only do we have them available, but that we're educating people on how to use them and how to read them. And I think for me, the fentanyl test strip issue is not just for people in active use. I'm an advocate for having them in bathrooms, in bars. We're working on getting them in the bathrooms on college campuses with the West Virginia Collegiate Recovery Network here in West Virginia. They need to not only be in places where folks are using heroin or methamphetamine or cocaine, but places where people might be experimenting with counterfeit pills. Because that's the unfortunate thing that we're seeing, particularly among young people. And we also have some concerns about vaping in young people getting to fentanyl that way. The third thing I just want to talk about just very briefly is naloxone. I think even with the over-the-counter approval of Narcan, there are other formulations and other brands that I'm hoping will follow suit. Those brands, obviously, and formulations will still be available in prescription form. And I think we also need to understand that it's wonderful that naloxone's going over the counter. I think one of the things that will do is destigmatize it a little bit. I think people are sometimes reluctant to respond to an overdose because they're like, that's a prescription drug. I don't want to get involved because I'm worried about liability. So I think as it goes over the counter, that will help with some of that concern. But I also think we're going to continue to need robust community distribution programs that provide that product for free, because the average person is not now and will not be walking into the pharmacy to get that. And naloxone is not like aspirin. I don't say I have a headache, I'm going to walk down the street to the local pharmacy here and pick up aspirin to get rid of my headache. I can't do that if I'm in overdose. I'm on the floor and I'm out. And so we've got to think about how can we continue to, yes, make that product accessible to the public, and anybody that wants it to walk into a pharmacy to purchase it can purchase it. Fantastic. I think that's fabulous. Step in the right direction, long overdue. But we also need to make sure that that product is in proximity of where an overdose is likely to occur. And so any way we can get that product out into venues like libraries, arenas where sporting events are happening, music festivals, college campuses, high school campuses, anywhere an overdose is likely to occur. And so one of the things we've been working on is we have a product called the One Box that we partner with a for-profit company to distribute. And the One Box provides emergent video instructions, 60-second, on how to administer naloxone. It is meant for any formulation or any brand of intranasal naloxone. It is not specific to any brand. And then there's a longer video training that if you wanted to onboard every employee, for example, in a library, they could go through that video training. And as we move naloxone over the counter and we start to see the state standing orders remove training requirements, right? Getting people comfortable with using those products is going to be essential. So from my perspective, huge step in the right direction. We need to wait to see what the FDA guidance is going to be. All indications are that Narcan will be over the counter by the end of the summer and available in that way. But we have got to continue. We need to proliferate naloxone in the same way fentanyl has proliferated our drug supply. And so it has to be as commonplace as a fire extinguisher or a first aid kit. And so with that, Sandra, I'm hoping I have a few more minutes. I was hoping to just show a video really quick, and then that will end my comments. So let me see if I can screen share. Yes, it's going to let me. Yay. I might have to minimize all of you to make this happen. There we go. It's no longer just heroin and prescription painkillers. Unfortunately, we're seeing young persons in particular overdose from taking counterfeit medications that are laced with fentanyl.
Here in West Virginia and Appalachia, you know, sometimes you just have to do what you're called to do and show up where you're supposed to. I arrived at the Answer the One box. Quite simply, it's a place to put life-saving naloxone that will give you emergency training when you need it on the spot.
Just open the box, you pull the tab down, and immediately there is a 60-second video with our friend Jan Rader talking you through how to utilize the intranasal naloxone in the box. There's also PPE here.
And the problem with getting the life-saving naloxone out to the people was the simple restriction that you have to be trained in order to use it. We simply didn't have a workforce that could go out and train as many folks as needed on this life-saving drug in time to save the lives we needed to. So we needed to scale that quickly. So the One Box adds a training component that can be administered in every home, every recovery house, or every workplace. Imagine right after you fill out your W-2s, you know, you're not really hired until you walk into the break room, open the One Box, complete the training, and sign off on it. That is a big step in changing this dynamic. That is the way we go from thousands of deaths into hundreds.
Oftentimes, if someone has overdosed, it's a very short period of time that you had to revive them and get them breathing again. This One Box allows the average bystander to be able to do it. And that we're wanting to look at putting these in our offices.
So I think one of our biggest accomplishments and one of the things I'm most proud of for our Collegiate Recovery Network is the fact that we were able to get the One Box on all 29 campuses across West Virginia. And we were able to do this on a voluntary basis. We didn't have to pass policy, we didn't have to pass legislation. Everybody was more than willing to get on board and, you know, really concerned about making sure that naloxone was available.
Institute was recently awarded a grant from the state of West Virginia, and what we're going to be able to do with that grant is to place One Boxes in every public library in the state. So there are 108 public libraries in the state. Every library will have at least one Box. We will train all the library staff on how to give naloxone, how to do naloxone training.
We've had great calls from sponsors like Gibson, who've been there for us from the very beginning.
We've partnered with Gibson Gives, the philanthropic arm of Gibson Guitar, and the Nashville Metro Police Department to put these in every live music venue in downtown Nashville. So we're able to put them where overdoses are most likely to occur. And we're going to continue to do this work until we've blanketed and saturated as many places as possible with this life-saving medication.
So in partnership with Gibson Gives, with the Drug Intervention Institute, and with One Box, it's one thing to say as a CEO, it's another thing to say as a human, as a parent, you know, did you watch and hope that someone else was going to solve this, or did you play a small, specific, leader-led role? And I want to be able to say that.
Because they saw the value in the product, and they also saw how we could work together to get these where they need to be as quickly as possible.
We're really, really excited about the opportunity to do this at Healing Appalachia. We think that this has the potential to really reach a lot of people. Everyone who goes through the training will also receive a nice little goodie bag, not only with One Box, but with some additional merchandise inside.
With Gibson's help, we were able to not only train 1,201 people on life-saving naloxone and give them a free One Box, but we were also able, right before Tyler Childers took the stage, to train over 10,000 folks from all over the country on life-saving naloxone right from the stage.
First of all, let me hear you sound off if I trained you on the One Box and naloxone over the past 2 days. Thank you. We're going to right now, though, train each and every one of you. Put your hands up if you're down for that. You want to be trained on naloxone? You want to save lives? Let's do it. All right, let's cue the video up. On this video, guys.
There's many features, functions, and benefits of the One Box, but perhaps the one that we hear back from folks about the most is courage. You open that box and it gives you the courage to respond to an opioid overdose emergency. Thank you all very much.
Thank you, Susan. And it's really interesting to for me to see the availability of naloxone in the United States and Canada. We do have it in libraries. It's freely given out to the public, whoever asks for it, also at pharmacies. So there are clear differences, obviously, between the countries' responses. We are kind of at the end of our time, but you can still type questions into the Q&A box, or if there's a quick question, I think we still have 2 minutes. And I know that all speakers will also be available to answer questions via email. If that is something you would prefer, I'm sure you can find us online. Are there any questions from the audience right now? I know we had some in the Q&A box as we were going, and they've been answered. Okay, if there are no other questions, then I'm going to thank all the speakers for their very interesting contributions, and of course the Orion Policy Institute for inviting us. And I hope you enjoyed the conversation, and we might hear from you via email, and if not, enjoy the rest of your day. Thank you.